So what about evaluation and management? Well, I think the guidelines are fairly helpful. I'm not sure how this projects, but this is from the Society of Urodynamics and what used to be called female urology, now genital reconstruction and female pelvic medicine. And it basically says that in the diagnostic approach that you use the symptom complex. You don't need a lot of urodynamic studies. You don't need cystoscopy unless you're trying to exclude some direct cause. Personally, I think it's useful to do an initial residual urine because that's simple. It can be done non-invasively with ultrasound, et cetera. And then once you make the diagnosis, the initial conservative therapy is to start with behavioral modification. And then the way the guidelines are phrased here is to then add pharmacologic therapy. Honestly, my opinion is that you use both simultaneously. You don't waste the time doing one when you know that combined treatment with the two, that is behavioral modification and pharmacologic therapy, results in a better improvement than using each one alone. And this is the same guideline that basically says that when you get to a point where you're sure that this has failed, then you go on to things that we won't discuss, the therapy for refractive overactive bladder, which includes in no particular order posterior tibial stimulation or chemodenervation with botulinum toxin or neuromodulation, mostly with sacral neuromodulation. So basically, these are the potential management strategies. If you were to summarize these very simply, decrease activation on the efferent or the afferent side of the mixture-Richton cycle. I mean, a perfect treatment would be cut out the afferent side as long as you retain the ability to voluntarily void, right? Decreased residual urine in those patients that have significantly increased residual urine and thereby increase the functional bladder capacity, decrease the volume of urine delivered to the bladder and therefore increase the time to activation, restrict fluids, and obviously treat associated or causative factors. Now, sometimes we forget that bladder outlet obstruction results or causes the symptom syndrome of overactive bladder. Actually, that's what most men complain of. They don't complain of a slow stream. They complain of urgency, frequency, etc. And the British have shown that if you relieve the outlet obstruction, then in about 60, maybe 70% of people in 6 to 12 months, these symptoms of overactive bladder will certainly regress, if not disappear. The same actually applies to patients with significant prolapse or significant stress incontinence who also have symptoms of overactive bladder. If you correct these, you will result in a significant improvement in the majority of these patients, these women, again, waiting a sufficient period of time. So it's important to rule those out. If you're talking about drugs, these are the ideal characteristics of a drug for overactive bladder. Block urgency, block detrusor overactivity, do not affect voluntary voiding, and minimal adverse events or safety issues. The key is uroselectivity, a term coined by Carl Eric Anderson, actually for alpha blockers, but in other words, just affecting what you want to affect and nothing else. Now, you have to remember that the treatment goals are symptom relief, but a realistic goal is symptom improvement. I don't think that you're going to completely cure any of these people unless they have a proximate cause, like a bladder stone, and you get rid of it. So I think the patient expectations, first of all, must be realistic. These are the metrics that are usually measured. Urgency incontinence episodes, the easiest one to measure. Urgency, probably the most difficult to measure. Volume voided and frequency, nocturia, and various metrics of the quality of life. Interestingly, the FDA never let urgency be used as a parameter on which to make a decision about a drug or put actually in the prescribing information until very recently. These are the AUA guidelines, the last time that they were looked at for overactive bladder. First-line therapy, behavioral therapy. Second-line therapy, behavioral therapy, which you can combine with drug treatment. As I said, I prefer to use the two together. Antimuscarinics or beta-3 agonists. Extended release preferred over immediate release. You can use transdermal oxybutynin. Most people don't because of these skin reactions. If inadequate control or unacceptable adverse events, you can modify the dose of the antimuscarinic or beta-3. No antimuscarinics in narrow angle glaucoma unless approved by the patient's ophthalmologist. Used with caution in patients with gastric emptying problems or obviously urinary retention. Before abandoning the use of an antimuscarinic, if they have constipation, manage that. Use caution with antimuscarinics when other medications they take have antimuscarinic properties because of the problem or the perceived problem with cognitive dysfunction. Use caution with antimuscarinics and beta-3 in all frail patients, and those refractory to this line of therapy should be evaluated by a specialist familiar with further treatment. What about behavioral therapy? Well, this is basically what it involves, and it's a little science in itself. It involves education about how the bladder actually works, about fluid and diet management. Avoiding diarrhea is basically behavioral modification and biofeedback in itself. Using timed and delayed voiding and using proper medications. It's useful to make sure the patient can exhibit contraction of their periurethral striated muscle, and then teaching them how to do this. It's called the knack if they can do that. One of the useful modalities that Diane Newman, our behavioralist, has basically taught me is to tell these patients to stand still and to do what John Delancey called quick flicks, that is, quickly contract and relax the periurethral striated muscle to act as a suppressor to the micturition reflex or to urgency, and it actually works. So basically, this is what behavioral therapy includes. And behavioral therapy by itself has been reported to be effective in reducing incontinence episodes over 50%. Remember, though, the knack refers to being able to contract the pelvic floor striated muscles, and quick flicks refers to contracting this area quickly, relaxing, contracting, relaxing to abort the sensation of urgency. This is Kathy Bergio's study that originally showed that whether you combine these two from the outset or use them sequentially, both interventions together have a greater potential to enhance outcome than either one. This study was done in only women. It took actually over 10 years to complete the same study in men, but the same result occurred. What about antimuscarinics? Well, first of all, how do they act? Well, antimuscarinics act during the filling storage phase of micturition, not during the emptying phase. So for many years, it was thought they just act by inhibiting the interaction of acetylcholine with the muscarinic receptors on bladder smooth muscle. Only in very high doses, when you're trying to induce retention, does that occur. They actually act on sensation. In the usual doses, they don't affect emptying. In higher doses, they can produce retention. In the overactive bladder patient in whom retention is not a goal, they act during filling and storage and not emptying. This is Carl Eric Anderson's diagram. The lower doses affect afferent activity. That's the therapeutic window for overactive bladder. The higher doses can affect voiding contraction, as in a neurogenic that you're trying to put into retention on intermittent catheterization. This is the International Consultation on Incontinence. This is a 1A rating, meaning good randomized control studies that show basically that all of these work. Oxybutynin and propyvarine, at least in the lab, have an additional action, additional to their antimuscarinic action, but they're classified in the same group. So basically all of those work. What can you expect? Well, these are median results. Now remember that median results are generally higher than mean results. So when you look at the results in a particular agent, make sure that you differentiate medians from means. For urgency urinary incontinence reduction, this is what you can expect, and this is the placebo effect. This is what I call the drug placebo effect, which I think is a good way of grounding results. This is urgency reduction. It's usually 2-to-1 over placebo, no matter what the urgency reduction number is. Frequency, not a great deal, although it is greater than placebo. Quality of life increases, any metric generally improved. The adverse events, which I think that you're familiar with, there was a big scare about cardiac a few years ago. Cardiac, not in clinical doses with antimuscarinics, not in the ones that we use. Cognitive, the only one that's really listed in any guideline is oxybutynin immediate release in the EAU guidelines. As you know, there is a big flurry about cognitive dysfunction with total antimuscarinic load. And it was thought that basically perhaps this was the end of antimuscarinic usage. Well, it hasn't been. And in fact, there are some studies that disagree with this. These are studies basically that agree with the fact that a total antimuscarinic load can increase the risk of dementia, can lower the age at which dementia occurs. And this occurs in patients that have the highest cumulative anticholinergic dose. So you should certainly at least be careful, especially in older patients, in using a combination of agents that have a high antimuscarinic load. These are the recommendations for antimuscarinics in the EAU guidelines in 2020. Yep, they work. Consider extended release like the AUA guidelines. If they don't work, consider dose escalation or offering an alternative antimuscarinic drug or a beta-3, or combine the two. More from the EAU. Now, read this carefully. The EAU, I love the EAU guidelines because they take no prisoners. There is limited evidence that one antimuscarinic drug is superior to an alternative antimuscarinic drug for cure or improvement of urgency urinary incontinence. Dose escalation of antimuscarinic drugs may be appropriate in selected patients to improve treatment effects, although with higher doses you can expect more side effects. So if you're going to compare one drug to another, I mean, this is what I suggest to you. The FDA puts in their prescribing information, or requires the company to put in their prescribing information, results in the phase 3 studies that show efficacy. This is what the FDA allows. They generally use means, not medians. And let's take the two most recently approved, solifenacin and fesoterodine. You can do this yourself. If you want to provide a baseline for the drugs, I think basically the results in the prescribing information are good baseline. And you can express as a decrease in whatever phenomenon you're looking at to allow a more straightforward interpretation of the data and to easily see the difference between drug and placebo. This is what I mean. This is taken from basically the FDA, the means for solifenacin and fesoterodine versus placebo in terms of incontinence episodes. You see, first of all, the numbers are less than means. These are means. And if you look at a comparison of the two, you basically look at why the EAU says, there's not a lot of difference that one of these drugs results in different efficacy measures than the other. This is for volume voided, and you can do the same thing, with any parameter as long as you can get back to a baseline. If you look at drug placebo ratios, which I think are very useful, this is solifenacin versus placebo for decrease in incontinence episodes. This is fesoterodine versus placebo. And just for comparison's sake, this is Mirabegron, the beta-3 agonist, which we'll talk about in just a second. More from the EAU guidelines about the elderly. The beta-3s are efficacious and safe. In older people, the cognitive impact of drugs which have anticholinergic effects is cumulative and increases with length of exposure. In older people, try to use behavioral modification, non-pharmacologic managements first, and use long-term antimuscarinics with caution. You can use antimuscarinics in men to treat the filling storage symptoms. Normally, antimuscarinics in men that are on other treatment for outlet reduction do not result in an increased post-void residual and result in urinary retention, rarely if the post-void residual to begin with is less than 150 cc's. Combining an antimuscarinic with an alpha blocker is more effective in reducing these filling storage symptoms and increasing quality of life than either alpha blocker or this should say antimuscarinic alone. Problem with antimuscarinics is that many times they are discontinued already after a year. Why is that? Well, it's a combination of the patient's feeling as though the efficacy really wasn't worth it in view of the adverse events, and also, at least in the US, sometimes the expense of the drugs. For neurogenics, the long-term efficacy and safety of antimuscarinics for neurogenic detrusor overactivity is well documented, again, from the EAU guidelines. You can combine different antimuscarinics to try and maximize your outcome, and use antimuscarinic therapy as the first-line medical treatment for neurogenic detrusor overactivity. What about the beta-3 agonists? Previously, it was only Mirabegron. Vibegron, the company went bankrupt, reasonable on paper. So Mirabegron was the prototype beta-3 agonist approved. How did it act? A direct relaxing effect on detrusor smooth muscle, but also the same kind of afferent inhibition that you see with antimuscarinics. There was only one. It got a 1A rating from the International Consultation on Incontinence. The efficacy for incontinence episodes, if you look at the figures in the FDA-approved prescribing information, these are the actual numbers for 50 milligrams versus placebo, and basically for 25 milligrams and 50 milligrams versus placebo. You can see that the drug-placebo ratios are not as robust as they are with the antimuscarinics. The side effects. Unfortunately, this was the killer. This in the low dose. This was why hypertension is in the prescribing information. There was an increased incidence of hypertension of the low dose, but not the high dose over placebo. Why did this happen? No one really knows. All the other numbers are actually pretty similar. You know, in my particular practice, I'll have to say that the occurrence of hypertension or increase in hypertension that I thought was due to the addition of this drug, you know, has not been frequent, if at all. This is the EUA guidelines on beta-3 agonists. Mirabegron is better than placebo. They felt it was as efficacious as antimuscarinics for the treatment of urgency urinary incontinence symptoms. The adverse events are similar to placebo. They obviously didn't think much of the hypertension either. Patients inadequately treated with solifenacin. Why did they use solifenacin? Because that was the study. May benefit more from the addition of Mirabegron than dose escalation to the higher dose of the antimuscarinic. In fact, if you combine Mirabegron with solifenacin, you get just about the efficacy that you get with solifenacin 10 without the additional antimuscarinic effects. You can use beta-3 agonists in men, the same as you use antimuscarinics, and they may in fact be safer from the standpoint of retention. There is another player in the market now. I would encourage you to read this reference. It gives you a good summary. Vibegron, a beta-3 agonist. What are the highlights? One dose, no titration. No appreciable CYP interactions as far as stimulation or inhibition. That's not the case with Mirabegron. No central nervous system penetration of this drug. No blood pressure or heart rate concerns in the prescribing information. The efficacy seems at least as good as Mirabegron. Alpha-1 adrenergic receptor antagonist for overactive bladder. The currently used ones seem to be effective, but only if the patient has bladder outlet obstruction as well. There's no evidence that monotherapy is effective in patients with storage symptoms, and the International Consultation on Incontinence concluded that basically it was ineffective, the alpha antagonist, for overactive bladder in women. Phosphodiesterase inhibitors in men. This is from the EAU 2020. They improved the International Prostate Symptom Score and obviously erectile function, but not the flow rate. So it's questionable as to how these work, but they certainly do improve IPSS over placebo. So they recommend usage of these in men with moderate to severe lower urinary tract symptoms, either with or without erectile dysfunction. And studies do exist showing a combination with an alpha blocker improves the IPSS over alpha blockers alone. In the US, the only one that's approved for this is Cialis. So I often use a combination of an alpha blocker and 5 milligrams of Cialis daily in patients with bladder outlet, men with bladder outlet obstruction who have overactive bladder symptoms. And I do not have a study to show you that that's better, but it certainly seems safe, and to me at least, it's effective. This talks about systemic estrogen. Systemic administration of estrogen actually causes worse incontinence than placebo. This is not the same as local estrogen use. The Cochrane analysis makes the statement that there seemed to be less frequency and urgency in women treated with local estrogen, not systemic estrogen, local estrogen. Refractory overactive bladder, just make sure it's not a misdiagnosis and it's not non-compliance of the patient with whatever treatment you have prescribed. The etiologies of failure of the simple overactive bladder treatment, they can be any of these on this page. Don't overlook overflow incontinence or a significant residual urine. Don't overlook these direct causes. Don't overlook any of these problems as possible direct causes. Remember, you can get significant relief by reducing bladder outlet obstruction in men, by reducing stress incontinence or prolapse in women. And if you truly have refractory, then you go to posterior tibial stimulation, chemodenervation, or neuromodulation. So I thank you very much for your attention. Sorry we went over, but hopefully you have a better understanding of the overactive bladder symptom syndrome now. Thanks so much.